Xin chào quý vị, các bác sĩ. Tên tôi là bác sĩ Camron Smith. Tôi rất tiếc vì không thể gặp mặt với các bác sĩ ở Đà Nẵng cho hội nghị này. Tôi hy vọng trong tương lai tôi sẽ có cơ hội tham gia hội nghị này và làm quen với các bác sĩ. Tôi rất mong muốn Việt Nam thành công về mọi mặt, đặc biệt về sức khỏe của cộng đồng Việt Nam. Vì như người Việt Nam nói, sức khỏe là vàng. Tôi xin lỗi vì không nói tiếng Việt lưu loát đủ để trình bày bằng tiếng Việt. Bây giờ tôi xin nói tiếng Anh. As I said, my name is Camron Smith. I am a assistant professor of radiology at the University of Kansas Medical Center. My subspecialty training is in breast imaging. I'll be speaking today about developing a population-based breast cancer screening program. This is the state of Kansas, in the center of the United States. The health system is located in Kansas City, which is the largest metropolitan area of the state. Our health system is a large health system with over 10,000 employees, over 800 beds, and is a National Cancer Institute designated cancer center. This is one of only approximately 70 in the United States. This designation allows us to be a part of clinical trials and offer the most advanced tools for diagnosis and therapy to our patients. These are some images of the facilities of the University of Kansas Health System throughout the city. The Department of Radiology has 61 radiology staff members. 6 of us are breast radiologists. There are 32 radiology residents and 6 imaging fellows. In the United States, breast cancer is the most common non-skin cancer and is the second leading cause of death for women. 1 in 8 women in the United States can expect to develop breast cancer at some point during her life. Prior to widespread mammographic screening in the mid-1980s, breast cancer death rate in the United States had remained unchanged for more than 4 decades. However, since the introduction of screening mammography, the death rate has declined by at least 38%. So who should be screened? How should they be screened, and how often? The bodies that I am a part of, the American College of Radiology and Society of Breast Imaging, recommend that women aged 40 years and older have yearly mammograms with supplemental screening for appropriate patients. This may be due to breast tissue density or other genetic or personal or family history factors that infer higher risk. To know a woman's personal breast cancer risk, she should meet with a competent medical professional, ideally by the age of 25, who can help her understand her risk and know when screening should start and how it should be performed. We use the Tyrer-Cuzick model for calculating risk, though there are others. This is not to say that these recommendations are without controversy. Different societies and professional organizations have made different recommendations over time. Recently, one of the largest recommending bodies, the United States Preventative Services Task Force, switched their recommendation of when to begin screening to 40 years from 50 years, though they continue to advocate for biennial screening as opposed to annual screening. There are myriad reasons for the differences in recommendations. What is not debatable is the data that shows how the most lives and life years are saved. This table shows that annual screening, starting at age 40, results in the highest percentage mortality reduction, the most life years gained, and results in the lowest number needed to screen to gain a life year, as compared to the other strategies. This table is another way of showing the same thing. Breast cancers in the United States peak in incidence in the early 60s, with relatively fewer cancers in the 40 to 50 age group. However, the greatest burden of life years lost is in this 40 to 50 age group. If we want to save the most lives and the most life years, we need to start screening at age 40. We don't have quite as robust data from Vietnam due to lack of centralized national cancer registry and other government statistical bodies, all of which are very resource intensive. But what we do know is that it is the #1 cancer in women in Vietnam, and that in 2022, it was approximately 29% of new cancer diagnoses. The incidence continues to rise. And women who present with breast cancer tend to present at later stage disease and with worse outcomes compared to high-income countries. We also know that breast cancer screening saves lives. Vietnam does not have a nationally supported breast cancer screening program. Should mammography be instituted as the screening modality of choice by the Vietnamese government or even the healthcare community? Listed here are some of the possible concerns regarding mammographic screening in Vietnam. First, that Vietnamese women's breasts are too small. However, we have men come through my clinic who are referred for screening due to genetic predisposition for breast cancer, and we are able to successfully screen these men, despite the limited amount of breast tissue. Proper technique allows for whatever tissue is present to be screened. It can be uncomfortable, though, and this can decrease utilization by the screening population. Next, Asian women have more dense breasts. This is not necessarily a scientific fact and may or may not be true. Many studies have found conflicting data. It may be that differences seen have more to do with age and BMI than with ethnicities. It certainly is true that mammographic screening sensitivity is decreased substantially in the presence of dense breast tissue, and that other screening modalities must then be employed to overcome this weakness, which increases cost. Having brought up the issue of cost, mammographic screening in general is an expensive venture. The machines are expensive, upkeep is expensive, technologists and radiologists are expensive. And finally, the idea of accessibility. We shouldn't be screening people who can't receive treatment, whether that be because they are too far from treatment centers, they lack funds for additional studies or treatment, or would not be able to have any follow-up for treatment of disease. These last 2 points are especially important in considering any population-based screening program. In regards to the economic feasibility of mammography, there have been numerous studies performed in numerous settings evaluating this. They are difficult studies to perform, not least because it's hard to decide what a human life is worth to an economic system. It's difficult to come up with clear answers. You can find articles on both sides of this debate. These articles and others are listed in the references at the end of my presentation. Sometimes a more practical approach can be helpful. In the United States, according to the US government, we have approximately 19,750 machines. Of the around 330 million person population of the United States, about a quarter of that, or 82 million women, are thought to be eligible for screening. That works out to be approximately 4,152 women per machine. If we assume that there are 300 working days, then that's about 14 women per machine per day. However, not all women get screened. Of this eligible population, ideally, at least 70% of the women would be getting screened yearly. If we assume that 70% of that number get screened, then that works out to 10 women per machine per day. This is a very doable number. My hospital system performed 23 screening and diagnostic mammograms per day per machine in 2023. Let's take as an example this Ho Chi Minh City. We'll assume that the population of Ho Chi Minh City is approximately 10 million. A quarter of that, so similar to the quarter of the 330 million in the United States that are eligible, meaning 82 million women. So a quarter of 10 million would be 2,500,000 eligible women. If we assume that there are 10 functional mammography units in Ho Chi Minh City currently, that's 250,000 women per machine for a year. If we take that number to the 70% that is more realistic and would be a good goal for screening, that is 1,750,000 women. Let's increase the number of working days and say that we have 350 working days. That means that this would work out to 583 women per machine per day that would have to be done. Obviously, this is not a doable number. How many more machines would be needed? If we ran these machines at 350 days a year and had a more manageable goal of 30 women per day, again, you have to remember that these machines would not only be used for screening, but would also be used for diagnostic purposes based on the screening results, as well as women who present with other findings. So with a screening goal of 30 women per day per machine, we would need 157 more machines in in Ho Chi Minh City. In the United States, a mammography unit capable of tomographic images can cost, on average, around $300,000, not including installation, calibration, etc. So if we took 157 times 300,000, that would be 47 million US dollars to purchase these 157 machines. Let's say that we use used equipment and older equipment that only does 2D imaging. We might be able to get that for 70,000 US dollars. The resulting calculation is 11 million US dollars to acquire these older machines to be able to screen the population in Ho Chi Minh City. Again, this doesn't include upkeep, parts, the mammographers, radiologists, etc. It's a significant investment. One of my favorite sayings that I find broadly applicable, and I think applies even here, is start where you are, use what you have, and do what you can. In developing a screening program, a country can build off current strengths and capabilities to do the best it can for population health. What other methods for screening could be considered? In the United States, supplements to mammographic screening include the clinical breast exam, ultrasound, MRI, and molecular imaging. We can also consider these as alternatives to a mammographic screening program. As MRI and molecular imaging are even more expensive than mammographic screening, I'm just going to be focused on these items here: clinical breast exam and ultrasound. The American Cancer Society does not recommend clinical breast exam for breast cancer screening among average risk women due to insufficient evidence of its benefit when used alone. The World Health Organization supports the use of clinical breast exam in low and middle income countries when mammography is not widely available, emphasizing the need for proper training of healthcare providers. Although there are a good number of studies that have evaluated the performance of clinical breast exam, only a couple prospective clinical trials have been performed, most notably in India. That study found a shift towards earlier stage at detection and improved survival, but no overall mortality benefit. However, the authors did note that clinical breast exam could be a valuable tool for diagnosis of breast cancer in areas where mammography or breast cancer screening programs are not widely available. A 2020 study that was a systematic review by Tran et al. Also found no direct evidence that clinical breast exam reduced breast cancer mortality. However, the authors also noted that clinical breast exam merits attention from health system and service planners in low and middle income countries where a national screening program based on mammography would be prohibitively expensive. So what's the bottom line? Many cancers will be missed by a pure clinical breast examination screening program, but it's better than nothing. However, it must be remembered that healthcare professionals would need to be trained to be able to perform this effectively. Let's talk about ultrasound. There's a lot of heterogeneous data about sensitivity and specificity. And you can imagine that given such different protocols, equipment quality, study design across the world. So it's really difficult to really parse through the immense amount of data out there on ultrasound's ability to detect breast cancer, especially relative to mammography. A meta-analysis in 2019 by Sud et al. Found sensitivity and specificity that was better than mammography. However, a different meta-analysis in 2020 found that mammography's sensitivity was higher than ultrasound, but that specificity was similar, and that overall ultrasound could not replace mammography in terms of breast cancer screening efficacy. This study specifically excluded many of the studies that had been performed previously and may have been included in this 2019 meta-analysis that the authors felt were biased or otherwise problematic in terms of quality data. Regardless, understanding the pros and cons of each screening modality can help us make good decisions. Mammography is especially useful in the detection of microcalcifications that ultrasound or even MRI may not show. It is also highly reproducible. However, it is relatively expensive. Patients don't tolerate it quite as well as ultrasound, and sensitivity in the setting of dense breast tissue is significantly impacted. This is a limitation that ultrasound can overcome. This stands for handheld ultrasound, and this stands for automated breast ultrasound, just to be clear. However, ultrasound can often miss extensive invasive lobular disease, ductal carcinoma in situ, or other processes, even sometimes very localized processes. It is also very operator dependent. The reproducibility can be quite low. It is much cheaper and accessible compared to mammography. Decisions about screening have to be made with these facts in mind. The bottom line is that ultrasound screening certainly performs better than clinical breast exam alone. It's also more affordable and accessible than mammography, and it is already more widely in use in Vietnam compared to mammography. In conclusion, screening mammography remains the best proven screening method that is proven to reduce mortality from breast cancer in women. Ultrasound is frequently used in conjunction with screening mammography to overcome the weaknesses inherent with mammography, but it has practical use as a screening tool, especially in settings where mammography is not practical. The benefit versus mammography remains undefined, but certainly there is a significant number of breast cancers that would be detected in a ultrasound-focused screening program. Recently, a study that showed the combination of clinical breast exam with ultrasound and fine needle aspiration showed good results and good promise, but more research needs to be done. The likelihood that Vietnam acquires the infrastructure to begin a national mammographic screening program in the next 5 years is low, and so we may need to look in other directions. The goal of a breast cancer screening program is to find more node-negative breast cancers. Clinical breast exam and ultrasound can be used together in a screening program that will find more node-negative breast cancers. And certainly this will have better results than just waiting for patients to present with symptoms. So what are practical policies that could be implemented to improve the health of the Vietnamese population? Training in clinical breast exam in appropriate populations where imaging studies could be obtained if there were positive clinical breast exam results. This could be focused on yearly examination of women aged 40 plus. Furthermore, ultrasound screening of women aged 40 plus. There's good infrastructure of ultrasound equipment in Vietnam. It would be ideal if this could be annual, but at least biennial if that is not possible. The cost of such a venture remains a significant question, and more research would need to be done to determine what the cost of such a program would be to the Vietnamese government and to the population. And this is an opportunity that you as radiologists in the country have the opportunity to participate in making this research happen. This might happen by having hospital-based or city-based cancer registries to track patient information, method of detection for women who do present with breast cancers and the outcomes of these women. By doing research, collecting data, and then presenting that data to the appropriate government individuals and recommending bodies within the country, the healthcare goals of being able to offer the Vietnamese population an effective screening program can be achieved. As healthcare access and resources increase, mammographic screening remains an excellent goal. These are the references that I used in the development of this presentation. Xin cảm ơn.